Order, order. Good afternoon and welcome to the Women and Equalities Select Committee. Today we will be looking at the evidence base on the safety and effectiveness of puberty blockers. And I want to welcome our panel. Thank you very much for attending today's session, and we look forward to your experience and expertise on this matter. We'll be hearing from Professor Gary Butler, Professor in Child and Adolescent Health at UCL, Great Ormond Street Institute of Child Health, Professor Simona Giordano, Professor of Bioethics, Centre for Social Ethics and Policy at the University of Manchester, and Professor Ashley Grossman, Emeritus Professor of Endocrinology at University of Oxford. Welcome all. Thank you very much.
Thank you.
And I will hand over to the first section of questions. That's David.
Thank you, Chair. My first question, I think possibly for you, Professor Butler. So, from a medical perspective and not taking into account the current ban on puberty blockers, can you explain to us what the process is for prescribing puberty blockers to a child in relation to gender dysphoria and any oversight that happens as part of that process?
Yes, thank you very much. I can explain the NHS processes previously, which are different at present. So when there was the existence of the Gender Identity Development Service, often called GIDS, which was a clinical service under the Tavistock and Portman Trust, which was funded directly by the NHS Specialist Services Commission, they would be the point of reference for all young people under the age of 18 in England and Wales who perhaps had some question around their gender. And that was a specialist service which was set up to review the young people there and to work out, explore within their background, their history, their family, their social environment, what actually went on. And that was usually quite an extensive review, according to the service specifications, usually with a minimum of 4 to 6 sessions over a minimum of 6 months, but often many years, particularly for the young presenting young people. Now, a small proportion of young people who had persistent, what was called gender dysphoria, which is a clinical diagnosis according to standardized processes of being a major discomfort with their gender being different from their biological gender, then they could be referred to one of the two endocrine clinics, either in London at UCLH or Leeds Children's Hospital, which had each place had a team of people who could assess the young people there as well, see whether there was when the diagnosis had been made of gender dysphoria, and a recommendation from the GIDS for puberty blockers, for instance, they would then be seen at one of the two centres, one of which I worked in London. And again, suitability for puberty blockers was assessed. That took at least a minimum of 2 appointments and reviews with assessment of competence or capacity and physical well-being and full understanding and full background given as to the implication of any intervention, including future fertility, sexual function, and long-term well-being, etc. And if somebody wanted to go ahead and everything was appropriate, this is all with full support in person by the GIDS members of staff in parallel, then the recommendation would be sent to the GP to prescribe. And there was what's called a shared care agreement, a sort of contract with the GP to provide the treatment. And that's very similar to what happens in the use of puberty blockers in the other forms of treatment, say, for instance, precocious puberty. In that respect, it was identical.
Okay. And during the actual treatment, what oversight would happen?
The young people underwent a follow-up programme with the endocrine team at 3 to 6 monthly to check on how things were getting on. But that was also in parallel to the ongoing psychosocial support by the members of the GIDS, who often would see the young person more often.
Okay, thank you. Now, if a child or indeed an adult stops taking puberty blockers, what happens to both children and adults if they stop taking the medication?
Well, we know very well from studies, some which I've conducted in my previous history in the field of using the treatment for precocious puberty, that the hormonal process from the signals or hormones from the brain, the hypothalamus, to the pituitary gland, and then to the testicles or ovaries, it restarts again. Depends how quickly it restarts, it depends how far somebody had got into their pubertal process, but in the main, relatively quickly. And we know that it's very unusual from follow-up studies from children who've received it for precocious puberty that there are no ill health effects in the long term, nor are there any negative effects on fertility recovery.
So can you just confirm, to your knowledge, the evidence so far shows that stopping taking puberty blockers is always reversible, pretty much always reversible, or sometimes reversible?
I mean, there is never an always in medical practice, but in the main, yes, it is recognised as a reversible treatment. And certainly from my clinical studies and those whom we followed up who have had treatment for precocious puberty, I cannot recall a case where it didn't restart, puberty didn't restart.
Okay. And what would the process be for withdrawing puberty blockers, and do you ever see any side effects to withdrawing puberty blockers?
The process is really just stopping treatment, because puberty blockers work in a slightly different way from other medical treatments and hormones, in that they effectively flood the message production through the whole reproductive process. They basically overwhelm it from working. And so because puberty blockers are very much analogous to the natural hormones, only a subtle chemical difference between the two. And so when you take that overwhelming treatment drug away, essentially, then it allows the natural processes, signals to restart. So there aren't any side effects as such. They are just a resumption of normal puberty.
Okay, thank you. Thank you, Professor Butler. That's really helpful. Did either of the other panellists, witnesses, want to add anything to those questions I've just asked?
You're just saying, I agree with everything Professor Butler has said. I'm an adult endocrinologist, by the way, not a paediatrician. So I deal only with adult patients, but obviously I'm aware, I have been for 40 years, of the introduction of GnRH and the GnRH analogues, and how it was first discovered that by using these peptides, surprisingly, you'd not only stimulate but eventually block the whole axis. But as I understand the situation, you use a puberty blocker until to a certain age, until an adult age, and then having stopped them, you immediately transfer them, or the great majority of these children, now adults, into the cross-sex hormones. So it's not as though you go back, as I understand it, you don't go back into puberty, you simply go into adult life hormones. Is that not right, Gary?
Yes, I mean, certainly in those who are trans male, for those who are trans female who are born as male, they continue on with the puberty blockers, or GnRH analogues as their medical treatment goes, until, as such, their treatment is adjusted, or until they would have the surgical procedure to remove the gonads or testicles where they wouldn't need it anymore. And in the recognised practice in the adult gender identity clinics in this country, it's usual to start puberty blockers or GnRH analogues in parallel with estrogen in a trans female person. That's the standard approach.
Just one minor point is that you referred to this patient population as children, and legally they would be minors, but biologically they would be adolescents. So as my understanding is that
yes, that's right. Absolutely, yes.
Wouldn't be prescribed or used in very young children for this specific indication.
Perfect. Thank you all very much. Thank you.
Thank you. I just wanted to come back to one of the points that you made, Professor Butler, and that was, you said that you don't recall any cases at all where hormones just went back to normal after using puberty blockers. How many cases have you worked on, would you say, throughout your career?
With certainly treating early and precocious puberty would run into the hundreds. I couldn't put in numbers on it, and certainly with the trans young people through both clinics in the country, it runs into the hundreds as well.
Thank you very much. Kirith.
Thank you, Chair. What other medical reasons are there for being prescribed GnRH analogues, both for children and adults?
Okay, I'll take that one.
Yeah.
So as I said, I was involved right at the beginning when GnRH was introduced, and rather to our surprise, as I said, after stimulation, even GnRH itself, better still with the analogues, you switch off the axis. And we did some early work using rat cells showing exactly the same thing. You give these things over a period of time, hours to days, and the whole situation turns off. And we had a lot of discussion at the time as to how this might be therapeutically or clinically useful. Initially, we wondered about things like breast cancer, turning off the ovaries, but eventually the major uses moved into, one of my colleagues was starting this, carcinoma of the prostate. Then you can then turn off testosterone, and that's now in common use as a standard treatment for some types of prostate cancer. For turning off menstruation and estrogen in women with really unpleasant endometriosis, and that's been very useful. Various other uses were suggested, but they're much less common. So to switch off the reproductive axis, in women it's mainly endometriosis, and in men it's mainly prostate cancer, adults.
Okay, but there are also other uses.
There are other uses indeed.
Okay, thank you. And how is the process for prescribing GnRH analogues to under 18s for health concerns other than gender dysphoria different?
Do you want to take that, Gary?
It's regarded, certainly in children and adolescents, as just a standard treatment. It's licensed. It's approved with a lot of clinical studies, so it is then just a recommendation from the treating paediatrician to the GP. We have, as I mentioned before to a colleague, that there is a contract, an arrangement, what's called shared care agreement, which is done through the National Society, an agreed approach with the GPs, so that they know what to do. It provides information, and information from what both parties will have responsibilities. But I think in the use of, in adults it's clear, and in children with true precocious puberty it is clear, but actually the majority of the use by paediatric endocrinologists in the non-transgender field is around managing the timing of puberty and puberty changes. Now this is borderline whether it is certainly licensed, but it's within the, I suppose, the in-between areas of off-label use. For instance, children who are perhaps going through early but not precocious puberty, in whom there is some form of emotional disturbance and disruptiveness in the family. Those who are on other parallel treatments, including growth hormone to manage their growth. They are often given puberty blocking as well to manage this pace of puberty. In particular, two groups of children, and this is common usage now in those who've had brain tumours and radiotherapy and surgery, and also those who are born particularly small and their growth doesn't catch up. They're able to, and it's sort of recommended that they are given puberty blockers in the teenage years to help with managing their growth and the outcome of the treatments, really. And again, that's just with contract with the GP. They're not dealt with differently from any other medication.
Okay. And are there any other things that a doctor might take into consideration when making these decisions? And are there any differences compared to prescribing puberty blockers for gender dysphoria?
Yes, absolutely. In terms of, as I mentioned to your honourable colleague, the full assessment from the psychosocial assessment beforehand, particularly around the diagnosis of gender dysphoria. I think the principal difference between the two types of treatment approaches that the paediatric endocrinologist is not making the decision to treat with gender dysphoria. That's the psychosocial team, whereas we are in the regular practices.
Did you have anything else to add? Yeah, thank you. Yes.
Just to add that in the treatment of precocious puberty, I think people want to refer to it now as premature sexual maturation, I think. Don't they? They don't like the word precocious. Anyway, that's semantic. It's neither here nor there. There are physical changes, often in young girls, often what we call idiopathic, no obvious cause, which can be quite distressing in a 5 or 6 year old going into puberty with emotional changes, and most importantly, with the changes in their bones, because they can undergo fast growth and then fuse their bones and end up very short. But there you have actually got a whole matrix of physical and biochemical changes, and you're changing, as it were, an abnormal puberty, hopefully into a normal puberty. And as Prof. Butler says, there's a huge amount of evidence originally from Harvard showing this is highly successful, and that the outcomes from these usually young women are also very positive in terms of fertility and their subsequent life. It's a slightly different situation as we're dealing with when you're changing a normal puberty into, quote, an abnormal puberty.
Thank you. Thank you very much. Samantha.
Hello. Thank you so much for coming in today. Really grateful. I'm just going to move on to some of the concerns and mitigations to do with puberty blockers, if I may. And so I'll ask this question, then you can suggest who's probably best to answer, and maybe all of you might want to answer. So what does the evidence say so far about the short and long-term physiological risks for children and adults who are prescribed gonadotropin-releasing hormone analogues for gender dysphoria?
I can answer this a very broad question. Thank you. And I think one needs to look into the aspects of long-term well-being of the individual concerned and their gender identity, and how that contributes to, and how any intervention might contribute to their living their lives according to their identification. And the other things, more specifically, you're talking about physiological. I know there were anxieties around bone health in particular. Would you like me to expound on either of those particular areas?
Yeah, please. We're really keen to dig under the physiological, so the physical potential risks.
Yes, I mean, the physiological, well, I know there's a lot of anxieties around the effect on bone health, for instance, because the background to that is that the process of growth, the bones get bigger and they acquire more calcium, which gives the strength of the bones akin to using concrete in a skyscraper, which would be quite flexible if you just had a steel structure. The amount of calcium in the bones accelerates during adolescence and into early adult life, so much so that your bones are the strongest by their mid-20s, so that acquisition period in the early years is quite fundamental. Now, if you are taking steps to slow down puberty, the bone mineral content, which is what the amount of calcium in the bones is, carefully monitored, and it's part routine, part and parcel of the assessments there. Now, there is a delay in when you instigate puberty blockers in a trans young person of the bone calcium going into the bones. It doesn't actually reduce, it just stands still, it doesn't increase quite as quickly. But what we know that from follow-up studies which have been published from Amsterdam, and what we in the UK are about to publish soon, is that bone calcium content recovers once sex hormones are started. And it would be the same, we know certainly from those who have treatment from precocious puberty, that the calcium in the bones also recovers. What is unclear at the present time is from the researches so far, is that it is a slower acceleration back to normal in the trans girls, trans women. But what the Dutch researchers have found, and we're sort of beginning to identify the same in the UK cohort, that perhaps the trans women start off with a lower calcium in the bones before they start puberty blockers or any intervention. We don't know why that is. It's not anything to do with any medical treatment. But these are some of the researches underway to try and throw some light on that.
So As research is still being done, does that mean we don't know how to mitigate that risk? Is there treatment you can give alongside which addresses the calcium in the bones?
Well, yes, of course. Things that are important are, which we always assess, is appropriate nutrition, vitamin D, and again, exercise, and also when sex hormone treatment is started, if that is appropriate for the person, then that is monitored as well. It's all part of the routine monitoring process in the Children and Young People Service.
Could I just add, you mentioned the use of GnRH analogues in the adult patient. When they're used in that situation, it's nothing to do with puberty. You know, I would use a GnRH analogue in a transgender female in order to switch off her testosterone, and that's purely as it would be in a man with carcinoma of the prostate, to simply turn off the reproductive axis and then treat her as appropriately with estrogens or other agents. But the GnRH analogue in the adult patient post-puberty is not involved in any way in pubertal delay at all. It's a different type of use.
And so would that have the same impact on the strength of bones?
Well, insofar, yes, because bone is dependent on testosterone. You switch off testosterone, so therefore you're at risk of osteoporosis and bone thinning, and then you replace that trans female with estrogens and other forms of bone protection, which you would normally do as a woman, as a normal female. So you're using in that situation as a way of switching from male to female. And therefore, there should not be any irreversible long-term effects on bone in that situation, in the adult.
May I just add a point to that, if I may? In the whole process of normal or typical puberty, there's a very wide range of timing of the events. So you can get some young people starting puberty, going through the process at age 8 or 9, and some it might not be till 14, 15, 16, etc. Now, the timing of the acquisition of increased bone density and indeed growth, physical growth, is going to be varied at that stage. So someone going through puberty later will have an apparently lower bone density, bone mineral content, as will be their growth. At present time, we have no way of being able to control for that. We do have for children's growth, I was a part of the Royal College of Paediatrics working group to establish new growth charts for children in this country, and we've included new growth lines for children going through early and late puberty because their relationship to the normal range is quite different. So someone who's going through puberty at the age of 15, 16 might appear to have shrunk compared with their peers. And the same with measuring bone density in when you're using puberty blockers. It appears it shrinks by standard methods, but actually the bones don't actually crumble or reduce in their bone content.
Okay, thank you. Want to say?
Please go ahead.
No, because I'll move on to another question, so I just want to check with you anything.
I wanted to ask if you were considering also other types of risks and benefits that are currently discussed, or just the bone?
Yeah.
There are two main other areas of concern with regard to puberty blockers. One is tissue availability and sexual satisfaction. And this particularly concerns trans women. And the second is the potential effects on the brain. These are two concerns. So with regard to the tissue availability, one concern is that if you stop pubertal development at early stages of puberty, what is known as standard stage 2, the penile development is not sufficient for the creation of a successful neovagina. The other concern is that if the person has not experienced orgasm before the vaginoplasty, they might have damage in the nerves or not have the psychological awareness, and that might result in poor sexual satisfaction later in life. These were the concerns. And recent research being carried out in the last 2 years has compared the sexual satisfaction outcomes in trans women who've had vaginoplasty without having received puberty suppression, or having received puberty suppression in later stages of adolescence, and trans women who have had their puberty suppressed early in life and then received vaginoplasty. And the results are not different, so there is a statistically significant similarities in satisfaction rates, which I think across the board were around 77% satisfaction rate, which we don't have, of course, cisgender satisfaction study scores, so we can't say this is a good rate of satisfaction or a bad rate of satisfaction. It's also difficult to tell what this satisfaction gets down to, whether it is having been followed up psychosocially and having had a lot of therapy and being able to discuss your sexual life openly. So it's difficult to pinpoint, but it's interesting that there was no statistically significant difference between the two groups. The other concern is around the brain development, and animal studies suggest that sex hormones affect brain changes. So one question is whether this would be true for humans as well. And of course we can't do the same studies on humans that we would be able to do on animals. Studies have looked at what can be looked at, and is cognitive functioning, executive functioning, and IQ scores. And again, we don't find a difference between, the scientists who've looked into this matter have found no difference in executive functioning, cognitive functioning, and IQ scores of trans young people treated with puberty blockers compared to the cisgender cohorts. I don't know if you have any other thing to add, Gary?
No, that's very helpful to know. Thank you.
Thank you. I feel like, I don't know if anybody, Sarah, I don't know what you think, that sort of feels like it's answered question 6, really. So my last question is, how would a physician balance these risks that you've mentioned and decide if and when the benefits of prescribing puberty blockers outweighs the risks of not prescribing them?
You want to take that from the ethical perspective, first of all, and then I can, because it's really from that perspective, isn't it?
These are kinds of, I think, balancing exercises that are ubiquitous in medicine. I think clinicians have to make those determinations every day. But one thing that I think is very important that I noticed from an ethical legal perspective, what was quite interesting for me, that when I started working in this area, a lot of clinicians were very concerned about the side effects of the treatment. And I read this in the CAS report as well. So we need to be very careful about the side effects, the known and potential side effects of the treatment that we provide. And that is missing out the consideration of what happens to the young person if they don't receive the medication, which incidentally is also a big part of the legal reasoning about the treatment of children that appears even in legal judgments like Gillick. So what judges said, clinicians need to consider what would happen to young people if they didn't receive medical treatment. And I suppose that clinicians, particularly psychiatrists and psychologists who are involved in the early stages of the assessment, will have to make that assessment. Can this person live satisfactorily without medical intervention, or is the dysphoria so significant that it will cause mood disorders, similarly to mood disorders that would be caused to young people who suffer from precocious puberty, anxiety and depression? Would they be able to attend school? Would they be able to integrate with other people? Would they become suicidal? So, and the vast majority of young people who are gender incongruent can function reasonably well without hormonal intervention. So it's only statistics, I think, are quite consistent across countries. It's only about 20 to 25% of young people who are seen by the specialist services who will actually be referred for endocrinology. And
That's right, yes.
So that's a kind of determination that psychologists and mental health professionals will make in the assessment. And when the risks of not treating seem to outweigh, then they would consider a medical treatment, and it seems to me that that's the right way.
Yeah, if I can add I'm not sure if it complements or in any way disagrees with your view. And again, as a non-paediatrician, my major concern is that there has been a huge increase, as we know, in referrals, whereas previously there were mainly youngish males, there now tends to be adolescent females. And my concern is that our assessments, not the endocrine assessments, but the psychosocial, the counselling and the psychiatric assessments, are not totally and completely validated. We know that adolescence is a very difficult time. We know that the brain during adolescence, the teenage years, according to work of Professor Blakemore, is highly pliable and it is developing. And there may be many reasons for these young women who may have problems at school, problems with their parents, who may wonder whether they're gay or not. There's a lot of social media influence. And the uncertainty, and my concern, is that we know the great majority of young women who are placed on pubertal blockers then go automatically and transition into the transgender state. So the risk is that we are placing a number, I don't know, but no one knows, of young women on this treatment who don't actually need it, and it may have long-term effects, we don't know. Now, as you rightly point out, the risk on the other side is that we are taking young women who are truly transgender and undergoing a great deal of dysphoria and distress and denying them the possible advantage of delaying puberty until a later age. But as you point out, I think quite reasonably, I think we have full information. We don't know how much not delaying puberty in these true transgender young women is going to be ultimately damaging to them. So I think it's a very difficult decision. I end up as a fairly personal point of view that these are highly potent drugs being given, and I would still describe them as children, with rather uncertain consequences. But there may well be a small group, and I suspect it's small, who would indeed benefit, but we can't identify them at present, I don't think, on the current estimates and psychometric and other assessments. Gary, would you like to talk anything about the assessment techniques?
I think, thank you very much. I think it is difficult to work out which assessments are best. I mean, observational studies which have been published have come under criticism for being of low quality evidence, because that is how the evidence hierarchy is formulated, that observational clinical studies are low quality by definition. And that's what has been published. And I think it's fair to say that a lot of the psychological experts are not able to agree completely on which are the best measures to try and assess what's happening to a treatment. There have been studies which have shown some outcomes, but not necessarily clear results, and that's where the challenge happens. And I know there is currently a reanalysis of a lot of those studies taking place within the German Central European countries, which are reviewing a lot of that evidence at the present time to see what that means, and they're due to publish their report pretty much any time soon.
And did you, I don't think we covered it up in my section, but one of my colleagues' section, did you say that if a young woman went on these blockers so she could present as male, that she feels like she was born into the wrong body, if they then stopped that treatment, physiologically there'd be no issue for them? Or
this is a question of presenting as male. I think it's a question of just the puberty processes, whatever the natural physiological changes brought about by testosterone and estrogen through puberty, that would be temporarily halted.
And then once they stopped, say it was a mistake later, they would physiologically be okay.
I don't think we actually have that information, do we? That would be a young female on, say, the age of 14, having a puberty blocker for, say, three years. then stopping and then deciding, actually, I'd like to remain as a female, would she then go through a normal pubertal process? I think
yes. Yes, there are some people who've been through that situation and chosen to stop treatments and the processes, both those born male, born female, the physiological processes have resumed.
Thank you. Thank you, Samantha. Before I bring Rosie in, could I just ask the panel if there are the same concerns and measures for mitigation for when GnRH is being used for other reasons other than gender dysphoria, say, for example, the issues of endometriosis or prostate cancer. Are there the same concerns for the patient using those as there are for gender dysphoria?
No, I don't think so. I think in this situation, you know that you have biological, biochemical and other measures of an abnormality, and you know that you're simply switching off the reproductive axis, and you understand why you're doing it and what the purpose of that happens to be with those measures. And huge trials have taken place, for example, in prostate cancer, to some extent endometriosis, showing if it's valuable or not. So I think this is a rather different situation because you are interfering on subjective, dysphoric grounds on what would otherwise be a natural process. So my personal feeling is these are quite distinct situations. So
safe for, say, endometriosis and prostate cancer, but not safe for gender dysphoria?
Yes.
Right. Does the rest of the panel agree?
If I could comment sort of physiologically, when I mentioned that the puberty blockers are used in other adolescents for other reasons, we would use the same measures as with a young person with gender dysphoria. We would look at their height, their clinical stage of puberty and hormone levels, and also you look at the changes in the bone growth as well with X-rays. So those things would be monitored in the same way.
And in the same way that any other medication would have an impact on bone density, there are other medications that have impacts on bone density. You can take measures to mitigate those. Could you just outline them again for the committee, please?
Certainly, shall I comment? It's probably different from adult practice, but in children and young people, the first thing is to ensure they're eating well and appropriately with adequate nutritional balance, particularly calcium in the diet. We always ensure that young people on those treatments will have vitamin D supplementation, which is not an exceptional thing for recommendations for adolescent health, and that they partake in physical exercise where possible, because that's also noted to promote bone health.
Thank you. Professor Butler, and have you noted throughout your work that those steps to mitigate the concerns have been successful?
By and large, yes. I think that's right. It's we don't tend to see a loss of the amount of bone, as explained to a colleague earlier, that we don't tend to see overall a loss of the total amount of bone in the calcium in the bone during the GnRH treatment. And that perhaps shortfall compared with the norms will catch up if that young person undertakes sex hormone treatment.
Thank you. Professor Giordano, did you have anything to add to that at all?
And just a small point perhaps on this, that there is no case in the literature reported of complaint around loss of mineral density from the cohort of the children treated since the mid-1990s. No report in the literature, no litigation, no complaint gone through clinical authorities from patients. Another perhaps very small point in terms of the increased rates of referrals. A recent study in Germany reports that there's been in the same years comparable increases in rates of adults referred to the services. So it would be interesting to see if that's the same. So the increases in referrals seem to concern adults as well as young people.
Thank you very much. Rosie?
Thank you, Chair. Dr. Butler, just following on from the Chair's question about have the steps to mitigate those concerns about bones been successful, can you explain how you know that? Do you personally follow up with your GIDS patients kind of throughout the process or years later or when they're adults? And I'd just like to point out to the panel that Kira Bell is sitting behind you, and you were mentioning earlier but that all of the processes have been resumed when treatment stopped. I think she and her court case would probably take issue with that, as would other detransitioners. But could you just explain how you know those calcium bone levels have resumed or been okay?
Thank you. My comment originally was with children having precocious puberty treatment, not necessarily in the gender field. Can I clarify that?
Yeah.
I know there are some situations where we don't know the full outcome in terms of every person who's received puberty blockers from the trans field. We don't know all the details yet, so I think that's fair. So I can just clarify that, please. And in terms of the knowing about bone health as a sort of marker of, I suppose, biological effect, well, yes, we follow all the children, young people prospectively, so obtaining data and obtaining them monitoring on a regular basis. We can see what happens as they go through the various steps and stages of treatment. We work in very similar practice to other major centres around Europe in that regard, and the information has already been in the public domain and published, certainly from clinic in Amsterdam, and our current researches, which we're doing in parallel with them, actually mirror those findings.
Wasn't there a study in Sweden that showed that bones were breaking quite often?
I don't know about bones. Breaking is very unusual to happen in adolescence. I think, as Professor Giordano said, that's not something that we would see because the bone, even if there is a change in bone density, it almost rarely gets below the range or into the range you'd expect fractures to occur.
Thank you. Dr. Butler, what outcome is prescribing puberty blockers supposed to achieve other than precocious puberty? I know we've touched on this a bit. I just want to drill down a bit on that.
Well, they've advocated as part of the process of managing the dysphoria in an adolescent young person, and as part of the recommendations, not only international but also from the service specifications from NHS England, to which we follow, who have asked that and have contracted with the various trusts to provide the service, that to actually begin to support the young people through their transgender journey, and this is one way of helping them in that regard.
Thank you. Do you know of any good quality evidence that Dr. Hilary Cass didn't look at that shows that puberty blockers achieve that purpose?
If I can refer back to perhaps some of the previous comments, it's about the type of measures that are used and how you're going to assess the evidence. The problem is, and I was working with Dr. Baroness Cass on the evidence accrual process through NICE, and it is very clear that according to the standard hierarchy of evidence, there isn't anything which would fall within or a very minimal amount in that high level of categorization, most of it being observational, in other words, just simple reports of what's happening at baseline or changes, but whether they're using physical or mental health measures, and that is again regarded as not sufficient in that categorization.
Thank you. Can I just ask you a bit about your time at GIDS? Why did you continue to prescribe puberty blockers when the preliminary results from the early intervention study in 2015-2016, which of course you were heavily involved with, didn't demonstrate clear benefit?
At that stage, the contract was within NHS England, who provided the framework for the service specifications. The contract was then through with the GIDS at the Tavistock, and the endocrine clinics provided support from that. So that was within the bodies and within the NHS England service specifications and their commissioning.
Okay, why were the results not published till 2020?
Well, I wasn't directly involved in that study, but the issue around a lot of studies having been involved with what are called longitudinal long-term studies in children, it takes a while to accrue the information and also collect the evidence of or information on effect or changes over time. And that was, according to the leaders of the study at that stage, that's the report that was given to the Health Research Authority. I mean, currently you're probably aware there's a National Institute of Health Research funded study looking at the longitudinal outcome of gender identity in children called the LOGIC study, and that has been ongoing for a number of years now. And clearly that's although there's some preliminary information coming out, that will help, I hope, provide answer to some of the questions that the committee has. But that's going to take some years before the information is sort of analysable.
Thank you. Dr. Grossman, you mentioned before about young women. You were a bit concerned about the number of young women who've been being prescribed. Given that the Tavistock GIDS found that a high percentage of its patients had an emergent same-sex orientation, I've written down that it was 68% of girls and 42% of boys, i.e. people who are just likely to grow up gay or lesbian. Are you concerned that puberty blockers are being used to change children from being gay or lesbian to being able to pass as straight or members of the opposite sex? And do you echo the concerns of some of the former GIDS clinicians that they were transing away the gay, in their words?
So I understand your question. Yes, personally, I am concerned. And again, I speak as an adult endocrinologist, not as a paediatrician with any great experience of paediatrics. But my concern is that I have quite a number of daughters. Adolescence, childhood, is quite a difficult time, highly confusing for quite a lot of children. We know anorexia nervosa is really quite a common problem now in young women, of uncertainty as their future, their sexuality. And my concern is not the endocrinology per se. I think as technicians we're very competent at doing that, but as the assessment of these young people who will put on a trajectory that takes them automatically into a transgender state. The original idea, and which I think some 10 years ago, I was asked by a newspaper how I felt about the concept of puberty blockers, which at the time I thought was not unreasonable. The time to consider, time to reflect, maybe for 6 months, that you would put everything on hold, and then see which way it's going forward. My concern about the work from the Tavistock and the Portman Clinic was very much that they were put on this conveyor belt and automatically transferred into a transgender state at the end with, I think, was certainly inadequate follow-up, but probably inadequate assessment in the first place of these young women who are clearly in a difficult situation. There may be many other problems going on. We know about problems with possible neurodivergence and autism, and that these were not properly explored. So my concern for the future is that there may indeed be a small cohort, and I would imagine it's probably small, of young women who wish to be transgender and which pubertal blockers may be of assistance, but we're not adequately assessing the probably much larger number of young women who, with adequate counselling, psychological support, would eventually decide they wanted to stay cisgender.
Before you move on, could I just offer that same question to Professor Butler and to Professor Giordano, please?
Yeah, that's what I was going to do.
I think, absolutely. I think as far as the numbers who were being referred to the GIDS, as everybody knows, went up exponentially from about 2010, 2015 onwards, which there is no, because that was happening across Europe and across the developed world, there isn't really a clear explanation for that. It is fair to say, and I think everybody realises, that the GIDS was overwhelmed by the numbers of referrals there because it was set up as a highly specialist service, as was the endocrine support. And as Professor Giordano explained, that as the numbers increased in GIDS, so did the proportion who were referred to endocrinology. So it was, again, a much tinier minority of those referred to GIDS, particularly those who were birth-registered females, actually ever got in the way of endocrinology. So we were not seeing them, and they were not. And furthermore, just to make it clear, because they had already gone through their biological puberty, there really wasn't a place for puberty blockers. Other ways of managing distress, say over menstruation, other hormonal methods.
Thank you. Professor, did you want to come in?
Yes, 2 points, I think. One, I would like to comment on the conveyor belt concern. I can't comment on how the services were stretched and how the assessment was in fact carried out, because I wasn't a part of that. But the international consensus and the recognized practice is to consider puberty blockers as a complement of a number of other psychosocial measures only and only in those cases where the young person suffers from what was called until recently strong and persistent gender dysphoria, which would not be alleviated by other means. In this cohort, persistence and persistence studies which have been conducted since at least 2016, it appeared that those individuals who, after the onset of pubertal development, would experience and continue to experience strong and persistent gender dysphoria would nearly always become later transgender applicants for medical treatment for transition, regardless of whether they had been given puberty blockers. So the correlation between puberty blockers, prescription, and later transition is not causation in this case, to my mind. It is most likely need that explains that correlation there. So that's one point on the conveyor belt. The second point concerns the benefit and your claim, Honourable Ms. Duffield, that the study published from the cohort, from the clinical trial concerning Tavistock, didn't show benefits. So how that puberty blockers don't have benefits in terms of suspending puberty is like to deny that the earth is spherical. For someone who is distressed by pubertal development, suspending pubertal development is clearly a benefit. The question is whether that benefit outweighs the risks and whether that benefit is justified. When the measures of benefits are taken, sometimes they are taken in a questionable way. For example, one point that has been made is that, and this was one of the results in one of the York reviews that then fed into the Cass review. Puberty blockers do not have proven mental health benefits because at follow-up there was no evidence, so the York study reads, that the mental health had improved or worsened. So the York study found that the people who had taken puberty blockers and compared pre and post found that having been on puberty blockers didn't improve their mental health nor worsened it, and took it as a suggestion that therefore what are you giving puberty blockers for? But actually from a clinical perspective, stability, not worsening, can be quite a good clinical outcome, because you can predict that a dysphoric adolescent will get worse and worse mentally. So stability can be a good clinical outcome. So you need to ask the correct question to have the correct answers and to understand benefit in the correct way. And the same is when people ask, well, it's not really beneficial because it doesn't have any statistically significant impact on gender dysphoria. That's not what puberty blockers are intended for. They're not a treatment for gender dysphoria, so if you measure the effect or the benefits of puberty blockers on reduction of gender dysphoria, you're clearly not going to find a benefit there. So I think questions need to be pertinent to have pertinent answers.
Thank you very much. David?
One final question.
You've had 7, which is nearly twice the amount of every other member,
Right, thank you.
Unless it's super urgent.
It's just based on something Dr. Butler said about the Tavistock Clinic being overwhelmed. Was it your experience that it was overwhelmed with more autistic patients? Because Dr. Grossman mentioned autism as being one of the comorbidities.
Well, with numbers of referrals, and NHS England were aware of that, but to my knowledge, no actions were able to deal with the expansion of the service at that stage.
Thank you, David.
Thank you. Just a very brief question, and perhaps all three of you can very briefly answer it as well. I want to just follow up on something Sarah asked you around obviously the concerns, the risks of taking this medication. You mentioned it in relation to treatment for cancer and so on and so forth. But obviously the big concern here with the ban is the impact and the risks for children of taking this medication. Now, and adolescents, obviously, for that age group. So the issues with bone density issues, the issues with the effect on the brain potentially, tissue availability for future potential surgery that might need to happen. Is that risk the same for children who are going through precocious puberty as it is for people who have gender dysphoria? And therefore, should we be having the same concerns about people taking this medication for precocious puberty as we should be having for people who are taking for gender dysphoria? And if all three of you can maybe just briefly respond to that.
Okay, just very quickly. I think you can see my general attitude, but in terms of my reading of all the data, and I know some of the major authors in precocious puberty, there have been no long-term problems. The long-term outlook in terms of bone, in terms of development, in terms of subsequent fertility, have been absolutely fine, and it's a very useful treatment, particularly for the very young child. Not so much for the 7 or 8 or 9-year-olds, but 6 years and below, the outcomes have been extremely positive. It's a routine treatment for these young children.
Okay. Dr. Butler?
No,
Professor Butler, forgive me.
I completely agree with Professor Grossman on that regard, because it is a routine treatment. So hence, from the paediatric endocrinology perspective, and I'm not just speaking for myself, but we don't see why there would necessarily, outside the sort of the psychosocial side, around the gender side, why there would be any other different medical concerns to be considered around using puberty blockers in an adolescent who's otherwise healthy. Because some of the other conditions we use that for children and adolescents with other medical problems in whom we would have more concern, but certainly not in this group. And one of the typical processes before offering any intervention is to assess for general health and look to ensure there are no other underlying medical problems, to ensure that the young person is healthy. And that's part of the routine practice. It has been in the service specifications all through the many years.
Thank you. And Professor Giordano, do you have anything to add?
No, thank you.
No.
Thank you, David. Thank you, because we've got 4 more members that haven't spoken yet. So I just want to move on to Alex, please.
Thank you. Can you tell me, what does it mean when a medication is prescribed off-label?
I suppose we can probably both answer that. Well, from the paediatric and the adult medical perspective. Shall I start on? You'll just go ahead, actually.
As I understand it,
yes.
As an adult endocrinologist, if a drug becomes licensed, well, there are various ways that you get the drug. The MHRA say, yes, it's going to be a safe drug, you can use this drug. The manufacturer then gets it licensed for a specific indication. And that means we're responsible for this drug. We think it's a good drug. You can take it. We know that it's available for that particular indication. If it's off-label, it means that you, as a physician, know that the drug is a safe drug, it's gone through MHRA, but for this particular use, the drug company has not licensed it for you, so you do it on your own cognizance. And there are many, many drugs that we use where the drug companies haven't quite got round to actually deciding they want to license it. It might be too expensive, whatever. But we still use it because we know from published data this is both safe and it's an effective drug in that situation.
I think absolutely, I fully agree. But as a paediatrician, almost everything that is prescribed or recommendation is off-label, including sometimes off-license as well. Some treatments, for instance, to treat premature babies who've got open ducts in the heart is treatments which you use completely off-license. It is within endocrinology, very little has a license for use in children, other things like growth hormone and puberty blockers. So it's expected that, and there are general guidelines, usually national specialist scientific society guidelines and international guidelines as well, to which we would refer to in use of these treatments. For instance, like using sex hormone treatments or other things, or even steroid treatments in children and young people. So it's common, and not just in endocrinology, in cardiology, rheumatology. It's only in the last 10 years or so has there been a specific requirement for the MHRA to ensure that if a treatment is licensed for children, that the trials are done in children.
Yes, maybe as well that in pediatrics, I mean, not only off-label prescription is common, but it is also necessary in pediatrics, and in fact it is endorsed by the Royal College of Pediatrics and Child Health.
That's right.
And also in a quite delicate area of psychiatry, child psychiatry, it is endorsed by the British Association for Psychopharmacology. Yeah, that's it, I think.
Okay, thank you. So does that have any bearing on the safety or the efficacy of any medication, and how are the risks and benefits of this approach managed?
Maybe I can comment briefly. Generally, in this case, it's the pharmacological agent is quite well known. Triptorelin is the type of GnRHA which has been authorized and licensed in the UK for the treatment of central precocious puberty, and the unlicensed use of this agent for adolescent endometriosis is also included in the British National Formulary. So it is a well-known drug in this particular case. Now, the use for a different indication might be experimental at the very start, although in this particular case, the cohort was remarkably similar from the central precocious puberty in that it concerned still adolescents and still for the purpose of delaying pubertal development. But at that particular time, the application might be said to be experimental. As knowledge builds up through clinical experience, through published studies, rather than unsystematically collected clinical evidence, the treatment becomes less and less experimental and more standard and routine. I don't know if you want to add something.
I think, thank you, I agree entirely. I think when a treatment is prescribed or recommended which is off-label, then it's the onus of the prescriber to ensure monitoring of efficacy and outcomes, and that's exactly what we do in our routine practice of any medication within children and young people, but especially in this field we have very extensive information around the monitoring of the welfare of the young people.
Did you have anything you wanted to say?
Oh yes. It's a very interesting area, but I think any clinician prescribing a drug for a patient has to be will work out the risk-benefit ratio, and that will depend whether it's label or off-label. We'll look at the possible benefits, the likelihood of benefits, the possibility of side effects, and how the two correlate with each other. Just anecdotally, some time ago I was asked to give a lecture on behalf of a drug company about a disease, a fairly rare disease, and I wanted to mention a drug which is in very common use and is a first-line treatment, and they refused because it was their drug and they had not recommended it to be on label. And on that basis, we reached a situation where I wasn't going to speak without mentioning this drug because I would have looked stupid, and they would not give me permission to talk about the drug, so the lecture was cancelled. But every clinician, every patient I see on a regular basis, and I still see patients, I have to think very carefully, even very common anti-thyroid drugs. Is it indicated? What are the risks? What are the benefits if it's label or off-label? And that's an ongoing process, and that's, we take responsibility for that.
I would like perhaps to add on this that the most likely reason why this particular GnRHA hasn't been licensed for this particular indication is that no pharmaceutical company has had a financial incentive to do so. If the company is the pharmacological company is already the market leader in this area, then there would be no increases in sales. But otherwise, a clinician could always go on and prescribe the agent in its generic form. So most likely this medication would have been approved for this indication had someone applied, because if we look at the studies that have resulted then in the licensing of GnRHA for central precocious puberty, these were fairly short studies with a relatively small number of patients, and they were open-label studies. That means that everyone knew who was taking the drug, so there was no control. So it is likely that actually they would be licensed with the amount of evidence that we have at the moment.
Thank you. So just to clarify then, is it fair to say that prescribing off-label is a normal part of the practice of a prescriber, and especially in paediatrics?
Yes.
Yes. Thank you very much. And could you tell me how the safety of a medication is determined and monitored once it's in use?
You talking generically or specifically with GnRH analogs?
Generically, just any medication. When you're doing that prescribing off-label, how do you go about that monitoring process that you talked about earlier?
Well, I mean, in the first instance, one's wanted to look to see, for the reason for starting a treatment is to produce some clinical effect, and is that actually happening? One would monitor the patient to ensure that happens, and that if there's any other appropriate monitoring to take place, whether it's blood tests, whether it's physical changes or radiological changes, that those happen. So really it's on the onus of the clinician, in most cases due to standard pathways, recommended pathways. But because there's such a wide range of treatments around, specifically with puberty blockers, we have a more extensive evaluation and monitoring process than we would with a child with precocious puberty.
Can you expand on that at all?
Well, we would see them after we would perhaps do more blood tests, more physical checks, or more assessment of the bone health, and also obviously clearly in parallel with our psychometric colleagues, we would assess their mental health as well.
I also say that in any specialty, there are usually very large numbers of guidelines, consensus agreements, protocols in the published literature, which you will try and follow. If you don't follow them, then you have to have a reason not to do that. But for any given drug, you should only use it if you have either experience of its use or knowledge of its use, and in that case you're expected to know these are the possible side effects, these are the common, these are the uncommon, these are the things I need to test for on a regular basis. But it is very much based on a consensus view of specialists in that area.
Thank you very much. And just finally, can a drug become more or less safe once it's been put into use, and if so, how?
I mean, there are a number of reports over the years of different treatments which have had to be withdrawn, not necessarily in our field. Well, it comes to mind one about 10, 15 years ago for weight loss, for instance. The common was withdrawn, but others get withdrawn from time to time, yes.
Yeah, definitely. I mean, I was thinking of the same drug, very good drug, it caused excellent weight loss, had a very significant, not unexpected side effect, and the manufacturers withdrew that. But there are other drugs which we simply become aware, this causes cardiological changes or pulmonary fibrosis, and we weren't aware of that before, and now we've got that information. There are yellow cards that you send out, and you will then start thinking, well, this has got long-term side effects, maybe I won't use it so often. So yes, those side effects do develop over time. And obviously, a lot of trials for drugs, which are very extensive, might just be for 2 or 3 years. 10 years down the line, maybe a whole different ball game.
Thank you very much.
Thank you. Are you drawing a parallel there to, say, the common use of Ozempic now as well, and Wegovy, and the unknown kind of future effects, and that was originally a drug for diabetes, wasn't it? And now it's got the side effect of weight loss. Is that where you were going with that? We can say names.
I wasn't thinking of that particular.
I wasn't either, but I wasn't. But it may well be the case in the future. I think Professor Grossman and I probably think is just one example, similar example, but all things need monitoring, everything.
Yeah.
Thank you very much. Catherine.
Thank you, Chair, and thank you all for coming in today. We understand the research trial is currently being established, and of course we don't want to prejudice that in any way, but we would like to understand how the research trial might be designed in this instance and what clinical questions might be asked. I don't know who wants to start.
Simona, would you want to take that on to start with?
I can start. I have a number of perplexities on the name clinical trial. Clinical treatment trials test new treatments or new combination of drugs or new approaches to certain therapies. And they have a structured phase process. So in the first instance, the new agent is given to a few healthy volunteers, and then it gets given to a few patients with the conditions. And then in the phase 3, the agent would be given to a fairly large number of the patients affected by this condition, and then there would be a fourth phase with a regulation and approved from in our country, the MHRA, and marketing, and then a check on a large scale after the product is authorized. Puberty blockers are already authorized by the regulatory authority, so they are only given off-label. So the trial would concern the application to transgender and gender-diverse individuals. And the claim is that through a clinical trial, we would strengthen the evidence base, and it would become clearer whether a medical pathway is preferable as opposed or as compared to a pathway that doesn't involve medications, that only include psychosocial intervention. And there are a number of problems and my concern is that using the terminology of clinical trial misleads the public into...
Excuse me, I think I said research trial, not clinical trial. Is that the wrong terminology, you say?
Well, a research program in this area would include, as you correctly said, a determination of which outcome measures are relevant. Now, as far as I understand in the CAST report, there are 3 key elements of debate which will be part of this research, which are bone mineral density, brain development, and fertility. Now, these 3 measures are quite difficult to study unless longitudinal research is carried out. So young people will have to be followed up into adulthood, and the measures that we would take in the short period of time in which patients are in the pediatric services are standard measures which we should expect clinicians to take anyway, without necessarily enrolling young people in clinical trials. The research would have to start with deciding which outcomes are relevant. Most clinicians would probably be interested in many other things apart from bone mineral density, brain development, and fertility. They might be well interested in cognitive functioning, sexual or psychosocial well-being, ability to attend school attainment. Many other outcomes might be relevant. And some outcomes might be also context-dependent. In situations in which people might have difficulties attending school, for example, school attainment and school attendance might be relevant outcomes to study, in others might be less interesting. So a research study is really welcome, but should be designed in a way that the outcomes, there is a conversation about which outcomes matter and why, and what is the most appropriate way to know more about those outcomes. And a clinical trial is generally used to provide evidence of a certain level, the grade evidence 1 or 2, which probably in this area, for many of the measures will not be attainable. So the concern is that if we talk about research trial or clinical trial, we give the impression that a certain hard evidence will be attainable, when actually we will know more about health outcomes only by conducting long-term research, longitudinal studies, and observational research.
Would you like to comment, Professor Butler?
If I may, thank you. Yes, I agree. It is a challenge. We welcome the recommendation in the CAS report for funded research, because that has been a challenge over many years. It's something we've not been able to obtain, and with inherent prejudice against trying to do this, getting more information in this field. So that is really helpful that the NIHR is going to undertake the funding of that. So that is good news. The other challenge, as we'd mentioned before, is what are the, and Professor Giordano mentioned, what are the right measures that you're trying to assess as success of an intervention? And that is a challenge for the research committee at the present time. I'm doing my best to support them as well, because trying to design a trial which will perhaps produce some good results, positive or negative, but at least definitive results, is a challenge, given the fact a lot of the measures of functioning and what we call psychometric measures or measures of quality of life are actually, in some respects, not very good. And the trouble is, when you give an intervention, you want to be able to look at it at the start of a treatment and once the treatment or completed, or a certain period of time later on. I thought some years ago that I was leading a national study of the effect of helping children's growth with growth hormone. We thought we had, with expert psychologists, designed the best study, and it appears that those children who were treated did just as well on the repeat of the questionnaire as those who did not receive any treatment, but they just got used to doing the tests and the assessments. There's a familiarity concept. So that is also one facet which perhaps makes the design even more challenging. But I think the only way, in my view, to really get an idea of whether an intervention is successful or not, agreeing with Professor Giordano, saying it's the long-term outcome. How is that affecting people in their lives, whether cis or transgender, and whether that made a difference or not?
So having said that, how can the study be designed to be safe and to come out with that outcome?
I don't know what is being discussed at the present time, but I wait to hear and will provide any support that one can.
Would you like to comment?
Yeah, I'd just like to bring one up. I think it's going to be an extremely difficult trial. from what Professor Giordano stated, that the pubertal blockers, the children, adolescents on pubertal blockers, they did not appear to, as I understand it, improve in their mood or their dysphoria, but the concern is that those who would not receive pubertal blockers would actually deteriorate and become more distressed, which I would fully understand. So if you were to have a randomized trial of these young people and give half the pubertal randomly, half pubertal blockers and the other half not, and then look at them psychometrically, psychologically, whatever sort of assessment you wished, my concern for running that trial is that the 50% who were receiving the placebo or no treatment would remove themselves from the trial altogether and would look for alternative means. So if they were sufficiently motivated to want to receive pubertal blockers, then if they were told they were not going to in part of that trial, they may withdraw themselves and therefore the trial will be vitiated. So I'm just bringing up an extra problem in designing these trials. Personally, I'm not sure how it would run. I think the retrospective logic trial, which Professor Butler is involved in, I think will be really interesting, because those are children who did not receive pubertal blockers because they weren't able to access GIDS. And even though it's not exactly randomized, nevertheless, it will provide very useful information. For a prospective trial, I'm a little sceptical as to how it can be arranged.
I think I'm done with my questions.
Thank you very much. Thank you. Christine.
Thank you very much. One of the things we're looking at in this is the ethical issues of the trials. And I just wondered, and I should mention before we start, this is an area where, as the Liberal Democrats Women and Equalities spokesperson, I've been working on a policy paper for the best part of a year at the moment. So it's just to, so you're aware of where I'm coming from in this. So would you say there are any safety or ethical considerations in only allowing access to a drug, particularly a drug that's previously been more readily available through a research trial?
Would you? Yes. It would be helpful if you would.
Yes. Yeah, the ethical issues, there are numerous ethical issues and ethical legal issues in providing a medication only within a research trial. And I mean, the most straightforward one is that in doing so, there is a risk that NHS England will actually violate fundamental principles contained virtually in all declarations and conventions on human rights as they apply to participation in research. For example, the Helsinki Declaration is not enshrined, but the UK clinical trial regulation states clearly that it is inspired by the Helsinki Declaration. And the Helsinki Declaration states that it is the duty of the physician to take equal care of those who participate in clinical research and those who do not. And the voluntary consent of the person of whatever age to participation in clinical research has to be protected at law. Now, providing medical treatment only at the condition that an individual signs up for a clinical trial risks really eroding that fundamental ethical legal principle. The other problem concerns consent. Now, in the CAS review, we read that consent will be sought for all the children enrolled in the clinical trial. This is partly proper. 16 years old will be the minority of those who take puberty blockers, because most adolescents will need puberty blockers earlier than that. But there will be a proportion of young people aged 16 and over will need puberty blockers. And they have a statutory right to consent on their own. So consent should be sought from them and not for them. Instead, under the UK clinical trial regulations, for minors under the age of 16, their consent will not be required. Parents will need to consent on their behalf. Now, this risks already skewing a bit the sample So part of the problem with the evidence that we currently have is that the results concern small cohorts and therefore have been deemed to be non-generalizable. But only providing treatment to young people who have supportive parents, excluding children in care, for example, or children without supporting parents, even if that would be only a very small minority of people, risks skewing the sample. So that's one problem. The other problem is that we get in a really convoluted situation where recognized practice is to provide puberty blockers only to those people who can meaningfully engage in the therapeutic process. There are very isolated best interest decisions made in this case. I know of one or two. So normally, a young person will have to be assessed for their capacity, for their competence, and for their ability to understand the risks and benefits of puberty blockers, balance them up in order to arrive at a choice. The ability to consent will be, in all likelihood, an eligibility criterion for obtaining puberty blockers. And yet, their consent to participation in research will not be required because it will be their parents who will have to consent on their behalf. So there are a number of, say, peculiarities that follow from the provision of medical treatment only within a research trial, which could be circumvented by providing treatment to all patients for whom the benefits ratio is similarly favorable, and then engaging in research on a voluntary basis with long-term follow-ups.
Would either of the professors like to add anything to that?
I come from maybe a libertarian type of background. For an adult, 18 years and above, I think they take total responsibility, and every discussion for every medication is discussed and taken forward on that basis. Below that age, particularly 16, fundamentally, I believe we need to protect our children. And I don't understand how a child, and more particularly their parents, are able to consent to a medical procedure of which we are uncertain. I find that very difficult to understand and get my head around the possibility of consent by a child.
I wasn't suggesting that children should consent on their own. In fact, thank you for making this point. I was just commenting on the convoluted situation in which generally again, recognized practice and clinical guidelines suggest two things which we would not normally expect. Would only consider eligible for treatment young people who prove competent to decide, but additionally, the parents' consent would normally be required. So it normally would either be one or the other, but in this case, most clinical guidelines advise that extra level of safeguard. Talking specifically from an exquisitely ethical legal perspective, that it's a rather convoluted situation where competence will be, clinically speaking, an eligibility criterion, but then the adolescent will not be asked for their consent. Somebody else will have to consent on their behalf. It's quite peculiar. I haven't come across a situation quite like this before.
Thank you. Professor Butler, you looked as if you wanted to ask something.
I think, as someone who's had sort of clinical experience in this area, I don't know if yourselves, as a member of the committees, are familiar with people who are transgender or living their lives that are different from their birth gender, but the distress, the anxiety amongst the young person and their families is very, very clear, the majority. And many of them at that time, despite psychological help or support, are just not functioning. So if one can provide that form of respite to prevent or reduce the physical changes and the functions that are causing the dysphoria, then that can restore the function of the young person and the family in that regard. And it's that balance of doing harm versus not doing harm. Where is the harm? Where is the balance? We wrote a review commentary on this some years back as to when your back is against the wall, it is very difficult not to be able to provide help where help is available. But I think the anxiety around access to treatment at the present time, my view is that the specialist teams are the portal for access to the treatment. But if this is highly restricted, it's only going to make worse the movement towards unregulated prescriptions and as is happening at present, a lot of young people trying to access these treatments from abroad without appropriate assessment, without appropriate pre-checks or monitoring subsequently, so goodness knows what is happening. And I think that is a worry. I've seen this many times up until now.
So would it be fair for me to characterise what you're saying generally as that there would be ethical problems with having a drug which was available widely, then restricted, because it would bring up these other pressures about accessibility and turning to perhaps other sources of getting the drug?
Yes, that is the case, but I think but there really needs to be careful, perhaps not restriction or control over, like with other drugs and hormone treatments in particular in the field of paediatric endocrinology, which are recommended only to be recommended, prescribed and administered by people with specialist training in the area. I think of growth hormone in particular.
Thank you. The other thing that stems from that really is, what information do you believe should be given to young people to ensure they're making an informed decision, as has been mentioned, about taking part in the trial? What constitutes an informed decision?
Well,
that's a difficult one, I know.
It is difficult.
There is a clinical aspect to this, what kind of clinical needs and understanding a young person would need to have. And then there is an ethical legal perspective. A clinical trial, which is the only way to obtain a medication, which, as Professor Butler was saying, is felt as necessary by many trans people and their family, is already by default vitiating the informed consent process. Most likely, from other research that has been conducted again on eligibility criteria, we know that these strict rules cause an alteration in the narratives, because people are so desperate to obtain medication that they will say what is expected of them in order to obtain the medication. There is a knock-on effect on the relationship of trust between clinicians and patients, and therefore all of these things somehow can become counterproductive in terms of what outcomes are we studying if we are not having reliable narratives, because from the start we have funneled individuals within a research trial that might well be perceived as coercive, because it is. The coercive nature of provision only within a research trial can have a knock-on effect on actually the reliability of the data that clinical services will be able to obtain.
Was there anything else you wanted to add to that, either of the other witnesses?
No,
No. I mean, I fully concur. I fully understand all the problems and the distress of many of these children and their parents. But I still feel at point uncomfortable with the use of a medication for uncertain long-term effects and uncertain short-term advantages because of public pressure and in girls who may or may not ultimately show any improvement. A trial, I think, is the only way to get the information to prove it one way or another. and it will clearly be extremely difficult. And I take the point that by saying you can only get this drug by being recruited into a trial cause its own problems.
Can I add one thing? There is one thing that is very clear, it's really a clear law in Europe and in the UK, is that clinical research involving children has to be justified on very stringent grounds, more stringent than the grounds over which medical treatment gets provided. And you cannot either start or continue a treatment trial, a therapeutic trial, like in this case would be, unless you were fairly certain that the benefits are highly likely to outweigh the risks and burdens. If you didn't know that the benefit-risk ratio is likely to be positive, you couldn't actually initiate the clinical trial at all. So the concerns that you would have, I think, are concerns that would logically go towards a denial of the medication altogether. And I think that that's quite draconian, if I may. But the research can be done, so we can improve the evidence base. My concerns are the feasibility of a clinical trial. What are we going to get through that? Are there more appropriate ways of doing research? And my understanding is that probably we have more appropriate ways to do research in these areas rather than clinical trial. And the second is a coercive nature is this being justified from an ethical legal perspective?
Yeah. Thank you.
Very much, Christine. Rachel.
Thank you. You'll be pleased to know this is the last set of questions, so thank you for persevering. Could there be any unintended consequences of the indefinite ban on prescribing puberty blockers for under 18s in relation to gender dysphoria?
Well, could I start with, at the present time, the only young people who are currently eligible to receive puberty blockers are those who had been assessed and monitored by the previous Gender Identity Development Service. There are no new initiations at present until the new services, gender services are established, but until the clinical trial is going, there's no provision to do that. And this is in accord with the NHSE guidelines and also the legal statute. So at the present time, there is a hiatus in the access of this sort of treatment by a lot of young people at present. And I think it's one of the situations which I hope will be looked at in detail as to what the outcome of the mental health well-being and the long-term gender identity, which I hope that in itself will inform the decision-making processes.
So what you're saying is there are people who've been assessed as being eligible to take the puberty blockers, yes, who won't now be receiving them.
No, those young people have been permitted by NHS England within a clause within the legal ban to continue or either access treatment. Most of them have now started the treatment and continue that, so that won't be withdrawn. But it's the question of new starts are currently not able to happen.
It's a related point, maybe slightly different. I'm concerned if you ban, as we do, puberty blockers, and at the age of 18, you're still entitled at that stage to undergo transgender endocrine reversal, the relevant hormones. I'm still unclear in my own mind if an 18 or 19-year-old young person comes to me and say, I am transgender, I wish to have the alternative hormone treatment, whether I am actually permitted to prescribe those drugs for that patient in the absence of full psychological assessment and counselling. Now, you can say to those patients, well, I think I will only do that when you have been fully assessed, but that may be waiting because of lack of resources for several years. And equally, speaking to members of the transgender community, one of their major concerns, these are then who are adults, is the amount of time and the number of doctors they've had to see before they could get, as adults, their preferred hormone treatment. And that would seem to me an extremely grey area, even for the adult. I think what we have, I'm obviously less uncomfortable with not giving the treatment to these children. I agree that's highly arguable. But once they're in an adult state, it is still a slightly grey area as to whether that patient can and should be given treatment. As I would understand it from the GMC, if a cisgender patient comes to me saying, I'm a male, lacks testosterone, a female, lacks estrogen, it's part of my everyday job to treat them. But if a transgender patient said, I wish to have the following hormones to optimise my state, I think it's a legally and medically rather grey area. I'm very inclined to go ahead and do that, but I'm not sure on what grounds I'm enabled to do that if they haven't had the counselling, which is not available. Yeah. So I'm just raising a further problem in this whole rather difficult area.
Interesting. Did you want to
I mean, it may be up to Parliament or the law or the GMC to actually give proper guidelines on this. At present, they're not there. And if we don't have the resources, which we clearly don't, for these patients to be seen fairly early, then we're in a sort of vague in-between world.
Well, that is what is happening with children, young people from abroad at the present time. The assessment is not being, they're just accessing medication. And so many young people are self-medicating at present with treatment obtained over the internet.
Yeah, that's a very serious concern. But there are also some kind of peculiarities in terms of the ban and the justification. So generally, a ban is issued when a medication is, for example, not regulated. So there's been cases of slimming pills or performance-enhancing drugs. They are sold without going through that rigorous process. The MHRA finds out, recalls. Or there is, as we were saying before, there is new evidence about unintended side effects of medications. And in this case, again, it is the role of the regulator to recall or ban a medication. In this case, it's quite interesting because it is not the medication per se that is banned, but the application. So endocrinologists can continue to prescribe that medication for off-license, incidentally, for adolescents with endometriosis or central post-puberty on license, but not for gender dysphoria. So that's quite a peculiar situation. Yeah. Comparable situations are when a medication is found to have unintended side effects only for one particular category of patients. So, for example, one medication increases the risk of heart diseases. In those cases, it will be doctors who will be told by the General Medical Council, you should not prescribe this medication anymore to patients who are at high risk of cardiovascular diseases. It's usually not the regulator to step in and ban the application. The regulator will inform the clinicians who will then not use that medication for that particular indication. Moreover, the other peculiarity here is that when that happens is because new safety evidence appears that shows these side effects. In this case, there isn't evidence of lack of safety. There are legitimate concerns, but concerns are not evidence, and there are two different concepts here. And there is, again, as I was saying before, no complaint specifically concerning puberty blockers. There's small regret rates that concern irreversible changes procured by gender-affirming hormones or surgery, but no specific complaint, no litigation concerning specifically puberty blockers. So, legitimate concerns, not specific evidence. The other thing that is unique is generally it is the MHRA that is tasked with assessing the safety of medications and recalling or banning a medication when it's proven unsafe. In this case, the MHRA has not been involved. So the government has taken advice by a different commission called Commission on Human Medicines, which I never heard of. It's a much less known commission. And the membership of this commission is quite interesting as well, because you would expect to have a pediatric endocrinologist there, but there was one pediatric endocrinologist specialized in respiratory medicine. There was no psychiatrist, no child and adolescent psychiatrist, no child and adolescent psychologist. So it's quite peculiar for me that it's not the drug but the application that has been banned, not on grounds of safety but on grounds of concerns, however legitimate, not by the MHRA but by another much less known commission.
Thank you. And then moving on to the next question. What evidence do you think needs to be available in 2027 when we're told the ban will be reviewed? And how likely is it that that evidence will be available by that point in time? Perhaps Professor Butler, you'd like to answer that one first.
I think it depends. If a trial is going to be established, which I hope they will be able to come to an agreement for an appropriate protocol, that will take a while to implement and recruit to. And if in this field we're looking more at longer-term outcome measures rather than short-term changes, that's the key. What I'm hoping by 2027 that we will have more information on the long-term outcome in those young people who have already received intervention. And that's something we're working to at the present, including from our other parallel study, this LOGIC study, which is NIHR funded, which is following through young people who won't have received any intervention, but will have been part of a research study and followed up prospectively. We will have more information then.
So I think, so you're saying that from this clinical trial, there may not be information available in 2027?
It depends on the design and whether they can ascertain robust measures which they can demonstrate in a trial to change over time or not. And that is the challenge of the design at the present time.
And Professor Grossman, did you have anything to add to that?
It's a very difficult point. I suspect a prospective clinical trial will not have that information available. Looking at the way that clinical trials run and the time course. The retrospective trial, which Prof. Butler has mentioned a number of times, LOGIC, that may well have useful enough data so that we can review the legislation at that time. And, I would very much hope so. Either way, all I'm concerned about is the welfare of the children. And if we have robust data that says, really, this is a very good treatment and we really should go ahead, and there are certain children who will really see advantage from that, I'm very happy to alter my view. And I think it's reasonably likely we'll have that sort of information so we can make an informed decision.
As long as we continue to get research funding, which is the challenge. It really is the challenge, actually, at the present time.
Yeah. Do you want to add anything?
Well, I agree with what both my colleagues said. The only concern is that I agree entirely that I think it's very unlikely that whatever clinical trial will start this year, luckily, will give us any information that we don't have already. There are over 200 publications with statistically significant results, which have been excluded from the reviews that have fed into the government decisions because they were mainly observational studies. And I think we need not to mislead the public into believing that in this area of care we will be able to obtain so-called grade 1 or 2 evidence, because that is only achieved through randomized controlled trials. And randomized controlled trials can't be performed in this case because blinding cannot be maintained. And from an ethical legal perspective, because potentially beneficial treatment cannot ethically and lawfully be denied. The welfare of the child, as Professor Grossman was saying, has to be the paramount consideration and has to come over and above the interests of science and society. So you can't withdraw treatment, even if you technically could, which you technically can't, because within a month would be clear to everyone who is in the control arm. But even if you could, legally and ethically you couldn't, because the interests of the child have to be the paramount consideration there. So what kind of evidence can we have in 2 years? I think it would be very interesting to have the evidence from the retrospective studies, but I think we also need to accept that in this area of medicine, as in many other areas of medicine, we might not achieve that grade 1 evidence. And that is perhaps necessary to change the goalpost and to accept that some areas of medicine have so vast repercussions in people's lives that what we want to measure is so nuanced that it can't fit into that scale of grade. And it's also ethically problematic to withhold medical treatment that is experienced as beneficial, that nobody has complained about, on grounds that there is not enough evidence yet, if what is meant by evidence is unattainable.
I mean, I'm just sort of thinking of similar, just going back to what you mentioned as side effects or potential harms that Dr. Cass looked at around bone density and fertility. And there are certainly hormones available and widely prescribed, including Depo-Provera injections, that have those similar potential harms that are still licensed for use. So are you sort of saying that there's a case for the drugs to still be available and used for this alongside a clinical trial, and that there shouldn't be a ban, but that there is a place for the drug to be used alongside clinical trials to gather more evidence?
In my view, as a clinical trial might not be the right way of doing research, and might mislead the public into believing that this study will give a level of evidence that is actually not appropriate to aim for in this area of care. But in my opinion, yes, the puberty blockers should continue to be a matter to be discussed between patients and families and clinicians. It's not a matter for the Parliament, it's not a matter for the legislator. It's a clinical matter that clinicians should be able, I'm not suggesting clinicians should give puberty blockers, but it is clinicians and patients and their families to have to make that determination within the safety that guidelines would provide. So usually within a multidisciplinary team, after a certain number of assessments have been made, but at clinical discretion. And the politics and law should perhaps tiptoe in this area to allow for clinical discretion, really.
I think if there were a wonderful new oncological treatment which had a very high cure rate compared with existing treatments, then that would still need to be proven by a trial, and you would hope that, would expect that most people offered that would opt for that. And I'm sure the children and young people if taking part in a trial, would opt to receive puberty blockers in that regard. The question is not so much the fact that those going through the new services would not assess people properly or put them forward for puberty blockers, but there is such a huge backlog which in itself is distorting the whole flow process and the assessment process. So the feeding into the trial isn't necessarily going the young people who are at the head of the queue waiting to get through to the new services for assessment are actually so far down the process of puberty that I think within that period of time, if the question is being asked as to what happens when you interrupt early puberty, we will never get there, unfortunately. And so that would take much longer to achieve any outcomes, I'm afraid, because if there are, I don't know what the current waiting list figure is, but it's many thousand. And the new services are doing their level best to get through the waiting list, but it takes some time.
Thank you. Do you have anything to add?
Well, no, I was just thinking through the point with Professor Giordano brought up time and again, and the one that you mentioned, is Provera going to be a dangerous drug in terms of your bones? No, we don't know. But every day I will see a patient and I'll explain the risks of a drug which I personally might not want to take at this dose or this way. But the adult and I will have a discussion and I'll explain the risks. They will understand them and say that this is a risk which is small, but I'll undertake because the benefits are great. I think the real problem here is that we are dealing with very young people and children, and in a sense where the state has become in loco parentis, we are taking responsibility for looking after these very young people, where we sometimes might feel that the parents, for one reason or another, might not have all the information or have their best interests at heart. And I think, as Professor Giordano points out, consenting in this situation I find really, really problematic.
Thank you. Thank you very much.
Thank you. Thanks, Rachel. And thank you so much to our panel and to our committee members for the questions today. We've done nearly over 2 hours. So I thank you very much for your time, for your expertise. And also, I would like to say thank you to everybody. We have had differences of opinion, but we've been able to do them respectfully, with understanding and with graciousness. And that's happened in this committee room. I hope that that continues to happen outside of this committee room as this discussion continues. I am going to ask for the public gallery to be cleared while the witnesses and the committee members stay seated, please. Thank you. And that brings proceedings to an end.